from the home setting and maybe the research setting to the intensive care setting. And so the first speaker, Miguel Gonzalez, doesn't really need any introduction in the world of airway clearance. He's going to be giving us a talk around the use of cough assist in the ICU, followed by George Nofodopoulos. He'll be giving the ProCom.
Well, thank you very much. It's great to be in this debate. Of course, if you know my work, I am a big fan of MIE in the ICU for some years. But I believe this is not a fight. George is a brilliant physiotherapist in the ICU, and I will convince him that he should use at least one MIE device for each 2 ICU beds, because I believe that he wants his patients out of the ICU. He wants it as soon as possible. He wants to prevent intubation-associated pneumonia. He wants the patients to wean as rapidly as possible. And I'm going to prove that this will be facilitated by the presence of MIE. Now, we know that the patient that is in the ICU intubated has several challenges. We know that secretion encumbrance is one of the problems. And if we solve those problems and be effective in solving these problems, we will change completely the outcome of this patient. We know that the patient have mucociliary impairment, and we know when the patient is intubated, this mucociliary impairment is even more impaired, not because of the disease, but because of the presence of the tube. Now, of course, we have to evaluate the patient. We have to know about physiology, but we know that the patient, the extubation will be facilitated by all of this. And for those of you that work in intensive care, we now have tools. We can do ultrasound, George. We can auscultate the patient. We can even see the flow volume curves of the ventilator to detect earlier the presence of secretion. And the team of Martin Tobin beautifully explained this, that we can look at this, and this is really an indication to start using MIE proactively. Now, I know people think that MIE device is a reactive device. It's not a reactive device. It's a proactive device, because these patients, when they are intubated, they have many times when they are extubated, sometimes they have no secretions, but they have secretions above the cuff. And when we extubate these patients, the patients continue to have secretions that rule of the cuff. So we have increased work of breathing, we have atelectasis, we have prolonged weaning. We have to understand that physiotherapy have a role of tools to manage these things. And I know George will say that there's a lot of techniques, manual inflation, chest wall compression, but we have to understand that the secretions need to be mobilized, need to be expelled also. And most of the therapy, most of the techniques that we use in physiotherapy, in the ICU, aimed at mobilization of the secretion and not the explosion. In intubated patient, the only technique we have to expel the secretions is really suctioning. And we also know that the patients, when they're not suctioning, they have more ventilatory-associated pneumonia that is really not associated pneumonia, it's tube associated pneumonia. So what's the evidence on this? In every paper that we talk about, post-extubation failure, weaning failure, the secretions are all on the top 3, top 5 of the problems. Related to post-extubation respiratory failure, difficulty weaning, even when we extubate the patients to non-invasive ventilation, we have failure of non-invasive ventilation thanks to secretions. It is being described in guidelines from expert centers that secretions are always a problem when we want to wean the patients from the ventilator. So a couple of years ago, together with two French colleagues, we created an algorithm that really tries to convince people to evaluate the expiratory flows and the cough flows of our patients before we extubate, and see after extubation if we need to measure the cough flows. Now, of course, after extubation, we can use lung volume recruitment. For example, this patient here, when he coughs, he has 0 cough flows. But when he uses a mouthpiece for ventilation, he also can air stack and have an inefficient cough. So what's the importance of MIE? So MIE, George, was used in the first ICUs of our history. The first ICUs were like this. And even in the 50s, in those ICUs, they have the cough chamber, they have the inexuflator, the coughflator. And now we have strong evidence that MIE is important And I have no time to explain all of this, but I have time to explain another paper that you are an author, and I can't believe you're going to say you're going to fight against MIE should be standard of care in the ICU when you published a paper just a couple of months ago saying that when expiratory rib cage compression associated with MIE has a significant impact on secretion removal. So, of course, we need to understand the different settings. So many patients go to the ICU, and MIE can prevent patients to be intubated. And this is described by the team of Valencia, our team also. Acute patients with ALS, they are not intubated because they have the MIE in the ICU. And if you look at very, very old patients, we are refusing old patients in the ICU because we think old patients will not be able to survive without intubation. That's not true. If we look at very, very old patients, we can put old patients in the ICU and prevent them to be intubated because you know that these very old patients also have problems with secretions. So going inside the ICU, patients are intubated, they have a lot of secretions, and look at the weaning parameters. This is the last guideline on weaning parameters. And look at the weaning parameters that they describe. Adequate cough and abscess of secretions. And if we only trust the current physiotherapy techniques, this will be a weaning failure. That's why most muscle weakness patients are considered unweanable, and as we said, it's a fatal attraction between muscles and lungs. And look what people write. They say that the neuromuscular patients can only be extubated if they have adequate cough, few secretions, and capacity to tolerate spontaneous breathing trials. And of course, these patients stay weeks and days on the tube, children, adults, and they offer the tracheostomy. Now, this I have conflict of interest because together with this co-chair of this session, we published this paper where we described for the first time the extubation of unweanable patients. Now, people confuse because they think that we are very good in extubating patients because we are very good on non-invasive ventilatory support, and that's not true. We only could extubate these patients because we could fulfill this criteria, and the criteria is to maintain the patients in room air on oxygen saturation above 95, and this is only possible with MIE in the ICU. So we use MIE through the tube with high pressures. You can see here that the patient is intubated. This is a Guillain-Barré patient. She will never have it been extubated if it was not for MIE. Even little babies. We use little babies with SMA type 1 of pressures of 60 to minus 60 with a very, very small tube, okay? And the patient did not levitate. The baby did not explode, okay? Even in COVID patients, people were afraid to use because of aerosol delivery. So we had to invent a little bit. So we capped the tube, and we continued to use in non-ARDS COVID patients. And of course, patients get atelectasis, and we only, since the cough assists look like this, we are using them in the ICU with spinal cord patients. And people say, oh, it's difficult to convince the nurses and the therapists to use the cough assists. Well, we use what the mothers know how to do it. So the families go inside there. So if it's difficult to convince mothers, how can it be difficult to convince nurses? I don't understand. And the inexsufflator is always next to the patient when the patient is extubated, and that's why we had 97% success rate. Now, this paper, we excluded neuromuscular disease because I knew that I would never, ever have the courage to do a randomized control trial would I have the chance to have a neuromuscular patient in a control group. For me, that's randomizing parachutes. So I I excluded the neuromuscular patients, and even in critical ill patients with no neuromuscular disease, we were able to reduce the reintubation rates with direct impact on NIV failure and post-extubation length of stay. Now, of course, you can argue that there's contraindications, but this is common sense. Of course, there's contraindications. There's relative contraindications, and there's absolute contraindications. Now, of course, George will speak to you about barotrauma, volume trauma, pneumothorax, but we have to understand the patient. We have to evaluate the patient. And of course, if there's a risk for trauma, we can tailor the settings, like Paddy beautifully explained in the previous debate. And now we can understand also which are the patients that are more risk of having trauma. Sometimes the patients are extubated and they have edema of the upper airway. So it's not glottic problems. It's like Tina said. So why, Tina, why don't you go to the ICU and evaluate the upper airway after the patient's extubated to see the efficacy of MIE in a post-extubation? Now listen, George, come on. Would you use MIE in this patient? I can't believe you not. But that doesn't mean that the cough assist should not be there. This patient has severe bullous emphysema. You can see here the big bubbles on the lungs, okay? And of course, if I use pressures, high pressures in this patient, of course, it will damage the lung. So this is really common sense, okay? Look at the big one it has here. This is a COVID patient. Here, this is a COVID patient. Would you use MIE in this patient with severe ARDS? Of course not. But that doesn't mean that the device should not be there, okay? Now, talking about tracheostomy, we know that patients in the ICU, when they are tracheotomized, they are suctioned 20 times a day. And we create severe tracheal trauma, mucus plugs. We miss by 80% the left main stem bronchus. So patients are being submitted to bronchoscopies like 2 or 3 times a week. Now I'll tell you, George, I will dare you to take a mucus plug like we did here on the cough, on the MIE with on suctioning or with bronchoscopy. This patient was doing 3 bronchoscopies per week. He had total atelectasis every week because of severe plug. And we took off his plug, mucus plug, in 5 minutes. So tell me, you can even do ultrasounds to prove MIE is very efficient. Tell me in the physiotherapy technique that can have this outcome in in 30 minutes. So to decannulate the patients, we need to have adequate cough flows, and this can only be possible if we have MIE. All the papers that we described, all the outcomes we described on decannulating patients to non-invasive ventilation, it's only possible if we have the MIE device. Now, George will tell you that there's no strong evidence. There's no Cochrane meta-analysis. There's no randomized control trials enough. Now, cough, I consider cough a basic need of a human being. Now, how can you randomize a basic need? So half of the patients we help them to cough, and half of the patients we don't help them to cough, just to satisfy Cochrane. I don't agree with that. So I think there's a way that we should convince ICUs to have MIE, and unfortunately there's still a way to go. This is the Dutch survey that says that only 21% of the ICUs have MIE in their routine, and also Emma Swingwood's survey say that only less than 40% of the ICUs in the UK use this as a routine practice. Now George will say, this is very expensive, but we are talking about ICU. And I'll tell you, George, if you have an MIE device as standard of care in the ICU, this will reduce the cost of an ICU. And as you say in Australia, there's no worries, mate. So, to have our results, as Einstein said, you should do this, to get our results, you should do our methods, or you will be insane. Insanity is doing the same thing over and over again and expecting different results. And I'm sure if Einstein were in ICU, he would want to use MIE. Thank you very much for your attention.
Miguel, thank you very much for a very passionate speech. And we'll just go straight on to the con side of that debate from George, and then we'll open the floor to discussions thereafter. George, I'd like to see how you tackle some of those comments.
I can first of all move the microphone upwards because it was very low for our previous presenter. I think that's one good way to start. The other good way to start is that I think Miguel did me a little bit of a favour because he introduced a lot of information that I thought, oh my God, all these complications with cough assist. So now we're going to talk about a more balanced approach. We're going to actually not inundate you with so much information, so many images. It was so fast, I almost thought, are you selling me something? So here we go. Let's go back. I hope you noticed the second slide. That's important, isn't it? MIE is a con. So what we're going to do, we're going to use a case study. We'll then do a bit of a brief overview of the use of cough assist in ICU. And then I will obviously very strongly advocate why cough assist should not be the standard of care in ICU. Here we have an unfortunate gentleman who is a 32-year-old male with myasthenia gravis in ICU post-thymectomy. The other issue with him was he had a significant psych history with schizophrenia and anxiety. So here we are at day one post-op, on high-flow oxygen, stable obs, physio went to the bedside, no obvious evidence of secretions, adequate lower limb muscle strength, more so than upper limb strength. He could deep breathe, but he had a very weak cough and he was very anxious. He kind of like refused to get out of bed. This is a snapshot of his observations. So what I'm really showing you are the time points for when physiotherapy happened, but also he had frequent myasthenic crises during that day. And what the arrow is pointing to is that there was a significant deterioration in his oxygenation and his hypercarbia. So this gentleman was difficult to treat. By day 3, he still remained in ICU on high flow, nil tactile parameters. Chest X-ray now was showing maybe some increasing left lower lobe changes. His cough was now a little bit more moist, still weak, but he was only clearing saliva. He did agree to mobilise out of bed. He was participating with some active cycle of breathing techniques, but he needed a yanker to clear those secretions. He had further episodes of myasthenic crisis and they were managed medically. By day 4, this is when things got a little bit more difficult. He was deteriorating, he was complaining of panic attacks. He was very anxious. You may notice on the X-ray the left hemidiaphragm is starting to rise. He was also very tachycardic, very hypertensive. He was having ongoing myasthenic crisis, so this was difficult. So we continued with more active cycle of breathing techniques during the morning. This was my junior physiotherapist who was reviewing him that day, and we didn't want to mobilise him because he was quite tachycardic, quite hypertensive. So the thing for me was there was this psych overlay and it was difficult to kind of extrapolate from him. These panic attacks I suspected were actually mucus plugging episodes. I think it was his fear of what was happening, difficulty to breathe. I reviewed him like that afternoon. So what I did was, and as Miguel mentioned, I can do lung ultrasound, which I know you can't do. So maybe if you did, you may understand a little bit more what's happening with your patients. However, we can see the left lower lobe, which is circled. You can see that we've got some consolidation. You're seeing there the left lower lobe, and you will see here that's the spleen, that's the consolidated lung. And I'm also showing you his diaphragms. For those of you that attended my session on the movement of the diaphragm, you can see movement, but actually that is not thickening of the diaphragm. That is actually just the diaphragms moving passively. So he only had minimal excursion of the diaphragm, only like 0.5 of a centimetre of excursion, and no thickening of his diaphragm. So he was weak. So day 4 in the afternoon, after I'd done the ultrasounds, things were a lot worse. So the gentleman was obviously tachycardic, hypertensive. Still, he had no tactile parameters, but I believe that was because he had such poor lung volumes. It was really, the secretion retention was actually very difficult to diagnose. So I had a discussion with the medical team where we're concerned. I wanted to do a nasotracheal suction. They were worried with his psych issues and his schizophrenia. He was going to freak out. They suggested the cough assist. So here we have the medical staff suggesting the cough assist. So I tried it. I tried what were standard settings, not what Michelle says. I didn't do plus 40, minus 40. I did plus 30, minus 30, because I was worried this gentleman had bulbar dysfunction. So I did want, Patty would suggest I titrated the settings. We also used low flows because we want to therefore minimise any more closure of the upper airways. It was not successful. I convinced him to do nasotracheal suctioning. That was also not successful. So these interventions were not successful. I did discuss with the intensivist to say that the interventions were failing. I recommended that this person was intubated. They wanted to wait. So we did wait. We waited for the following day. I don't know how he lasted that day, that evening into the following day. By day 5 at the beginning, you'll look at this morning. That following morning, that patient significantly deteriorated and was intubated. So this is, for example, where we can maybe summarise the findings. This was a difficult case for anybody to treat, physiotherapy or medical. He had bulbar dysfunction, poor inspiratory, expiratory muscle strength, secretion retention, the cough assist failed, nasotracheal suctioning failed, so the debate's over. I kind of think that this is a failure. But we don't stop there, because now, again, Miguel alluded to the evidence base. Well, I can give you a better summary of the evidence base rather than flashing up images of titles of articles and making gross generalizations, because what we have here is we have really only maybe 580 patients that have been studied in intensive care, and the problems are they're observational trials, very few randomised controlled trials. I know Miguel did one, but it was a small sample size, randomised crossover trials, one systematic review. So, I mean, we're saying we should give MIE to everybody? I don't think so. My thoughts on extubation failure are important as well, because Miguel alluded to this, and we hear these magic numbers of 160 litres per minute, 200 litres per minute. But remember, post-extubation failure in intensive care is not 50% like it was in your trial. I think you obviously had a very, very sick cohort of patients in your randomised controlled trial, so I'll criticise you on that. Normal extubation failure rates in ICU 10 to 20%. Therefore, extubation failure does not occur just due to peak cough flow. There are many variables. You did not allude to these. You've got heart disease, you've got respiratory disease, increasing age, pneumonia, tachycardia, rapid shallow breathing index, weak inspiratory musculature. This is a really good systematic review. And these cut-off values that we talk about, I know Michelle in her impressive review again advocates this 160 to 200 litres a minute. But when you look at the intensive care literature, because this is what this is about, we are not talking about the 1950s, we are talking about what's happening now in ICU. The peak cough flows that are associated with good extubation outcomes is greater than 60 litres per minute. So you do not need a cough assist, which is going to get you peak flows of 200 litres per minute. Beyond that, this has also been shown, this systematic review, this trial actually, good observational trial by Guimaraes' group, also demonstrated that whether you were tubed or untubed, and whether you had the cough spontaneously or delivered by suction or delivered by active effort, the peak cough flow was similar in terms of the diagnostic accuracy for successful extubation. And look at the values: 60 litres per minute, 55 litres per minute, 45 litres per minute, 75 litres per minute, no matter how you triggered cough or facilitated cough. And this was also cough without the tube. So this kind of adds to the fact that the tube, yes, does not allow you to cough, but the values were the same. Importantly, we now know, and we need to go beyond the 1950s, because we are aware lung protective ventilation is important, which means moderate levels of PEEP, not allowing lung decruitment, and not over-ventilating lungs with 60 centimetres of airway pressure and causing trauma, because it's about protecting the lungs. We use other strategies like proning, steroids, reducing fluid intake. But cough assist is all about high pressures, airway disconnection, lung de-recruitment, forced secretion clearance. To what end? You guys are not measuring sputum. Nobody measures it. You tell me you've magically cleared all these secretions, but quantify it. Make me actually worry about it. So how much lung stress are we always causing with these interventions? So in summary then, Miguel, the key indications for mechanical inexsufflation in ICU, let alone, I think, across the board, are unclear. We don't know what peak cough flow we really need, because you guys won't do randomised controlled trials. Most of the evidence in ICU are single group, small observational trials, and most of the evidence is short-term impact, physiological measures, maybe about safety. That's about it. Peak cough flow within ICU generally is you only need more than 60 litres per minute with better extubation outcomes. And I see Miguel there nodding his head, but that's because he doesn't believe in evidence. So the unknown potential impact of MIE is adverse effects with airway disconnection, high pressures, loss of PEEP, decreased effectiveness with bulbar dysfunction. But what I want to finish with is Miguel very rightly said, I cannot not use cough assist in my patients because it is unethical. Now, this is bullshit. This trial, which looked at a randomised controlled trial of a decompressive craniectomy for persistent intracranial hypertension, they were randomised to craniectomy or no craniectomy. You tell me that that's not ethical. These people did what they needed to do, because what they did demonstrate was, out of these 150 patients that were randomised to decompressive craniectomy versus standard medical care, yes, the craniectomy reduced intracranial pressure, but 6-month outcomes neurologically were worse in the craniectomy group. So don't tell me you should not do a randomised controlled trial on cough assist, because I don't believe you. Thank you.
George, if you stay there, Miguel, do you want to come and join him? I'm sure. I think you've prompted a little bit of debate in a few people in the audience, including my co-chair. So I think we'll wait to see if anyone from the audience wants to come up and ask a question. Otherwise, we might unleash John. Sorry, it's a question for the audience first.
Hi, thank you very much. My question was about talking about the individualization of mechanical insufflation settings. Something that we didn't talk today about was about the gradient between exsufflation and insufflation pressure. Marcia Volpe published 2 years ago that optimizing maneuvers of mechanical insufflation with higher exsufflation pressure than insufflation pressure could increase mucus displacement and increase the expiratory-inspiratory flow bias, and that was maybe a better outcome than peak expiratory flow, and it was more focusing in ICU patients. I don't know what's your opinion about that.
Okay. Well, I will reply. Of course, there's a place where you should individualize the settings is in the ICU, of course. Of course, you have to know what kind of patients you're treating. You're treating patients with lung disease or with patients with severely mucociliary impairments. So then you have to learn what you learn with the chronic patients and try to apply in the ICU, always respecting the physiology and the severe impairment that the patient has in the ICU. So if there's a place where you should tailor the settings, is in the ICU, even with high expiratory pressures and high and more increased expiratory times. Now, let me tell you, George, I never said I would not do a randomized control trial. I said I did one. However, there's patients where I would never randomize, because with the evidence that we have, when I have a paper that I have 97% success rate, this is a more success rate than penicillin, and penicillin was never randomized. So when I have a paper with 150 patients consecutive, where I extubated the patients with MIE, and I have 97% success rate, of course, I would not do a randomized control trial on that population. So I did a randomized control trial on other population to prove what I expect to have. And let me tell you, you don't know that because you're not supposed to, because I had to stop that study in the middle. And you said that the number of patients were low, and that's true, because in my interim analysis of my ethic committee, I already had significant results. So the ethic committee did not let me finish the study with 100 patients for each arm. And I said that to the editorial board of critical care, and they accept the paper with that number of patients. So this is what we're talking about. And of course, did you see that 2 X-rays or CT scans? I would never, ever use MIE in a very, very severe lung disease patients like that. So really, the question is, this is the question, should the MIE be standard of care? I think, is suctioning standard of care in the ICU? Tell me.
Of course it is.
It is. So MIE is non-invasive suctioning. That is my opinion.
I need to make a couple of comments.
John, do you want to come in?
I have to make a few comments. First of all, Miguel, it goes beyond this. That Cochrane study that George, you cited, in not one of those papers was the cough assist used at optimal settings. all of them were 40 centimeters of water or less. That entire thing was useless. Now, another thing. If you have bronchitis, George, or I have bronchitis, and I don't cough at all, I'll be dead within 2 hours, okay? It is inconceivable to not cough when you've got secretions in your airway. You cannot do a randomized controlled trial when your intervention replaces a vital bodily function or a vital bodily organ. There are many, you're going to do a controlled trial for a renal dialysis? Wait a second. You can comment on all of this. You mentioned that all you need are cough flows of 60 liters per minute. I know the paper you're citing. They were not cough flows. The patient was intubated and created 60 liters a minute of flow by using his expiratory muscles to blow that air out, okay? That's not a cough. And those patients had muscles. Wait a minute. My patients have zero vital capacity.
John, you need to give me a time to respond. Because
so do you agree that you can't do a control study when it's a vital intervention?
Let me respond, because what you didn't understand with that study which showed different peak cough flows, they studied cough flow or peak expiratory flow with the tube in place for with 3 attempts or 3 different ways with the tube, and the last method was with the patient extubated. So there's no difference in the prediction of whether the patient's required intubation on the basis of that expiratory flow with or without the tube, John.
Do you agree that the bottom line is the greater the expiratory flow, the more powerful to expel secretions? That a flow of 300 is necessarily better than 100 liters a minute? Do you agree with that?
Not necessarily.
Oh, really? That's very interesting. We should have a show of hands about who agrees with the greater the cough flow, the more effective the cough, as opposed to a flow of 50 liters a minute or 0. Because my patients often have 0. And when we extubate them, we have a 100% success rate except on upper motor neuron diseases. And what did you show? An anecdotal study of a patient with traumatic brain injury who is strictly upper motor neuron. And what did you do with your myasthenia gravis patient? You let him suffer there, schizophrenic as he is, unable to breathe, for days with requiring oxygen supplementation because he was loaded with secretions because you didn't even use the cough assist. And then what did you do? You used the cough assist at 30 centimeters of water pressure, which is virtually useless. And then, when you extubated him, you said he was tachypneic. Of course he was tachypneic. You didn't extubate him to non-invasive ventilatory support.
Can I respond? Because I know the case. I know the case because you don't. That patient had bulbar dysfunction.
Sure.
And using high pressures is not going to be beneficial in regards to bulbar dysfunction. So it's not about... Wait on, John. It's not about high pressures, especially with collapsible airways. You know that.
And my SMA1 patients have no bulbar muscle function, and I still get almost 400 liters of flow with the cough.
I think we could have more questions.
Yeah, more questions. I got more questions. And you said measuring sputum. If you normalize the saturation by expelling the secretions using the cough assist...
ask George
my
a question.
goodness.
Now, George, we agree that the secretions should come out, right? We agree about that. We agree that the secretions should be expelled.
Okay, all right.
We agree on that.
Okay. I agree with that with a tentative agreement, because the problem we face, like you guys do, like we do, we have not quantified the impact of secretion retention on patient outcomes, because certain individuals, or we obviously believe very strongly in what we do, and we would advocate that therefore it's unethical to do something. I think unfortunately, unless we can determine specifically some measure for secretion retention, which we still do not have, it's difficult for us to understand the impact of these interventions, because...
But you suction.
Just including suction, because the problem is, you tell me how many trials that are using suctioning, physiotherapy, probably more with physiotherapy, that are quantifying the volume and the weight of secretions that are being removed. Very few, if any...
You published one.
I did, but very few cough assist trials do. Yeah. So the problem we face is we don't know what we're treating.
So, okay, but you agree, I guess...
I do in concept, but we haven't...
Let me ask you a question. In your ICU, you suction patients?
Of course.
Okay. In average of what? 2 times a day, 3 times a day, depending on the amount of secretions? Correct. Now... you understand that when you suction the patient, you miss about 80% of the time the left mainstem bronchus.
We don't just suction. You know that.
I know.
We use physiotherapy on top of suction.
But of course, but when you suction, You do physiotherapy, but none of the physiotherapy techniques that you use, back squeezing, chest wall compression, whatever you use, it does not contribute for the secretions to pop out. You have to suction the patient, right? So, if you miss in 80% the left main bronchus, and I've proven to you, and I didn't show the movie, but I have examples that, and you understand that the negative pressure comes from both both lungs. Okay, I can assume that the secretions are more cleared in the left main bronchus, and I will challenge you to look at that with ultrasound.
I don't agree with that concept, because the concept you're talking about is you're actually saying that because you're connecting negative pressure with a cough assist, you are causing or extracting secretions from both lungs. What do you think is happening when you trigger a cough? You're actually having expiratory muscle contraction, which will cause clearance of secretions from both airways, both lungs. So your argument is not valid. What you're alluding to is that if you suction and you hit the carina and you do not trigger a cough, then yes, if the suction catheter goes down the right main bronchus, fine. You're only clearing that, but that's a rare occurrence because our patients are not paralyzed. All right, so your argument is not sound.
They have neuromuscular weakness. So I challenge you to ask your awake patients when you suction, and I hope that none of you in the audience haven't been experienced of being deep suctioned. I challenge you to ask your patients, suction or MIE through the tube, what would they prefer to clear the secretions?
That'd be a good study.
Yeah, because Michelle, you've been waiting patiently for a question.
Yeah, it's a really passionate debate. They all have been. And in reality, the indications and the arguments work both ways. I mean, my take-home message is I would not use MIE on every single patient in the ICU. And I think that both of you would agree with that. So I think for the audience, it might be helpful just to have an idea over the select patients where we think maybe we should think about this first, because it's not for everyone, but it's also should never be used.
Good question and good proposition. I mean, I worry when I can't provide, for example, manual chest physiotherapy techniques. So I could imagine it would be ideal to use the cough assist in situations with somebody who's got unstable fractures of sternum or spine and you can't apply manual assist cough. Situations where you can't do, for example, standard care. And I think in that situation, it would be very useful. Somebody with an ascending paralysis, spinal cord injury, yes, very much so. Somebody with global weakness, very, very poor expiratory musculature, yes. I think I would try more conservative interventions first, because for me, it's the loss of PEEP and the potential for de-recruitment and the fact that most ICUs now have closed suction. It's not we don't like to disconnect. I mean, but there are situations where, for example, if a patient was pharmacologically paralysed with an absent cough reflex, I actually think sometimes then, yes, cough assist would be ideal, because you know standard suctioning will not be effective. That, for me, is how I'm thinking, how it could be useful.
Good question again, Michelle. I would be, instead of worrying in which patients I should use the cough assist, I would worry on the patient that I should not use the cough assist. And that's my worry. Yeah. So I would use the cough assist in probably 80% of the patients in the ICU for secretion clearance, and the other 20% are the ones that on the physiology point of view, I would create damage to that lung. Okay. And that's for me. And when you speak about randomized control trials or evidence-based physiotherapy, there has not been one randomized control trial on rib cage compression, back squeezing, on any physiotherapy techniques. The only randomized control trials on intervention of physiotherapy in the ICU is early exercise and active mobilization. There's no evidence whatsoever. So if we want to wait until there's evidence-based medicine, we would never treat the lungs in terms of physiotherapy in our ICUs.
Yeah, Miguel, thank you very much. I'm afraid, as you said, it's a very passionate debate, but
hang on. I got one last comment. About the thought of quantitating sputum expulsion, okay? Patients who don't want trach tubes and are intubated for well over a month, they have to wait that long just to get paid to come to be transferred to us. When they come to us, they're stable, but I normalize their CO2 and turn off the oxygen. Their baseline sats are less than 95, 83% of the time. Then we use the cough assist through the translaryngeal tube every hour or two until the saturation baseline normalizes, which over 80% of the time is in under 3 days. When the saturation is less than 95 in room air, there's only 3 real possibilities. Under ventilation, which we correct, airway secretions, or atelectasis and intrinsic lung disease. Well, the cough assist used through the tube normalizes the saturation baseline in under 3 days most of the time. And it's doing that by clearing airway secretions, and there's no other way you can interpret it. So that's the last thing I'm going to say.
Yeah, no, John, thank you very much for that. I think it's been a very, as you say, passionate debate, and hopefully has cleared the air a little. I'd like to say thank you to all of the speakers and the co-chair, and thank you very much for joining the session.